Welcome back to part 2 of my interview with Dr. Saba Maroof. In this episode, we'll address self-medicating with marijuana, dealing with eating disorders, involuntary hospitalizations, and so much more. Let's get started. So we'll go ahead and move on to self-medication. A lot of my patients would rather self-medicate with alcohol. I shouldn't say a lot of my patients. I do have a few. Self-medicate with alcohol or marijuana, and medical marijuana is becoming the go-to for anxiety and depression. I know all the research that I'm aware of on medical marijuana or marijuana use in general has been done on fully developed brains. I try and steer a lot of patients where their brains have not fully developed, 28 and below, to stay away from illicit drugs. What are your thoughts about that, if you can talk about self-medication with marijuana or other substances?
Yeah, definitely. That's really a big topic, especially right now, as more and more states are legalizing the use of marijuana. I'm in Michigan, and it's been a few years since medical marijuana and now recreational marijuana has been legalized. Oftentimes I'll have young people, adolescents that are coming in that do say that they've found some relief with it. And so I really kind of try to meet them where they are and say, okay, well, let's look at the fact that you are finding some relief from it. That's showing me that you are dealing with anxiety, or, we kind of try to explore why they're using. Oftentimes questions I'll ask are you using mostly socially? Is it kind of a social thing? Is it something that you do for fun with your friends? Or is it something that you're doing when you're alone? Is when you're having a difficult, many times people will say yes, for anxiety or to help them sleep. And so basically I tell them, like, okay, look, there's a reason why people use this. There's a reason why you're using it. It's kind of to help with kind of some of those negative emotions and to kind of help you relax. And there is something positive there, like you're getting something positive out of it. However, I really feel that, we really, the belief is that the kind of the negatives far outweigh the positives. So you might have some immediate gratification. However, oftentimes, even for anxiety, it's like it actually can over time make your anxiety a little bit worse. And definitely, yes. And I definitely tell them about if they're younger too. I know there's a researcher at Wayne State that looks a lot into this, into substance use. And she really, and she's almost like, I just discourage it for especially children and teenagers under the age of 16, for sure. And I really try to emphasize the impact that it can have on the developing brain, especially when it comes to cognitively, learning issues, motivational issues. I mean, there definitely is that amotivational syndrome. And it can be really difficult, to be honest, sometimes working with young people that are, that have developed somewhat of a dependency on it, that feel that it's the only thing that can help. And, we try to have this conversation that, like, I can definitely work with you to kind of help you with that anxiety. And, but if you're going to continue to use marijuana, it's going to be a little bit difficult. I would also talk to them about the fact that we don't really know how marijuana interacts with medications. And there, that is something to kind of take into account. We think that possibly it can make medications less effective. And I mean, it can become kind of a little bit of a power struggle too. And so, I mean, I know there are some other psychiatrists or even other physicians that are okay with the use, but I really try to kind of dissuade and not use it, I really try to discourage people from using it, especially, again, if they're self-medicating for anxiety or these feelings, these negative feelings, because you're not really kind of addressing the actual issue.
I do feel that most people that are addicted or have addictions, they started out trying to self-medicate themselves for depression, for anxiety, for ADD, for whatever symptoms that they're trying to figure out. Nobody goes in and says, I want to be addicted to marijuana, or I want to be addicted to alcohol. So, but at the same time, we mentioned yesterday that we're in the middle of Ramadan, and a lot of people are fasting, and medication compliance can become a big issue with people that are fasting. But also, there are people that have that probably need medication and they're not taking it. So how do you deal with medication compliance for people either not wanting to take medication or get treatment, or people that are not wanting to take medication due to Ramadan?
That's a really good question, and it's definitely something that we need to talk more about. I think this kind of is also another area where possibly there is stigma in talking about fasting and the use of medications. So many of our medications, I would say many of them are kind of more once a day medication, and so that I just try to talk to people about. I mean, again, we treat so many different conditions, and so it depends on what condition it is. If it's something that you're taking once a day, then it should be okay. Basically just obviously everybody's routines are off in Ramadan, whereas before maybe your cue to take your medication is when you brush your teeth or after breakfast or something like that. Obviously, our routine is just really very different in Ramadan. And so really trying to working with people, how can we remember to take it? Are things too rushed in the morning? Are you too tired to take it in the morning? Then, maybe for this time being, you can switch it to bedtime if you can tolerate it, if you're still able to sleep and everything. And oftentimes if they've been on medication for a long time, it's kind of in their system. The timing doesn't matter as much for some people. But now there's other conditions. I know that we've had discussions even with patients and even family friends, for example, with ADHD. So it's really important to talk to your doctor a few months before Ramadan, and that can be the problem. Sometimes we don't think about it till right the week before Ramadan starts. But it's really important actually for students. It can be a challenge, if they're studying for exams, like finals, things like that. When should they take their ADHD medication? And there are other options for that. There's actually a new medication that's a newer form. It's still Ritalin, which is, we've been using that for decades. But it's actually a medication you can take the night before now. And that was really developed to help with parents that have a hard time in the morning with their kids and making sure that their kids take their medication as they're going out the door. But that could be a really good option for somebody that has ADHD. Because the problem is that even if you take it at sahur time, it's going to run out, it's going to wear off, especially with these long fasts. So there's that. There's also some ADHD medications and even other types that are available as a patch. And you should, of course, talk to your, local, imam or whoever you kind of follow, where you try to get kind of your rulings from. But I did ask a few of our local religious scholars, and they felt that a patch is okay to take, to take while you're fasting. So those are just kind of some practical kind of solutions. Now, I guess we go, if you're going into some of the more serious mental illnesses, such as bipolar disorder, is a really big one. One of the things that keep people stable that help keep their mood stable is having like a good schedule. And making a big thing is kind of what we call there's circadian rhythm, and circadian therapy is kind of another term, making sure that you're getting enough sleep. Not getting enough sleep in it of itself can trigger in some people a manic episode. So I know my patients that have had bipolar disorder for years, they know that, and they really kind of make sure that they guard their sleep as much as they can. And if they feel like their sleep is off, then they kind of know, okay, something is kind of going to be off. Again, Ramadan, sometimes sleep can be an issue. We're going to have more interrupted sleep. I would say now with quarantine and being home, I think that's kind of been a silver lining of this Ramadan, is that we're sleeping a little bit better. We don't have to get up and get going in the morning to get to school at 7:30, 8 o'clock in the morning. So that's kind of been a blessing. But many of the medications that we take for bipolar disorder or for any kind of psychotic kind of disorders, they can be twice a day medications. So that's something you definitely want to have this conversation with your doctor too. There is going to be a subset of patients, I really truly believe, and as I'm talking to other mental health professionals, psychiatrists, Muslim psychiatrists, and mental health professionals, and reading about it, there are some research papers on this. I really do believe that that there is an exemption. If you are at high risk, meaning like if anything, either lack of sleep or not being able to take your medications on time is going to cause a recurrence or basically trigger an episode. And if you've had episodes that are so severe that you might have to be hospitalized, or they just really cause a huge disruption, I do think that could be a cause for exemption. Now that's something to talk to your, again, I hope a psychologically minded religious leader about, and maybe your doctor about, and collaborate. But I mean, that's something that kind of really take seriously. I did have a patient who hadn't fasted for many years, but she wanted to try to fast again. And she was on a twice a day medication. And in that case, we said, okay, well, let me, make sure that I can contact your family can contact me. We're going to monitor you very carefully, because she really wanted to try. And so we kind of had that collaborative approach. But really, it's almost like with the first sign of anything kind of, because it's easy also to say that I really do think that you're exempt from fasting, but fasting, as we know, is something that's really special to people. It's not something that people are really going to let go of. It's not a act of worship that people are readily giving up, right? But at the same time, we know that if you have an illness and chronic illness, then God has, does exempt you from that. And there's other ways of worshiping. So it's definitely basically worth having a conversation about. And again, like this conversation of exceptions and God's mercy and things like that. Another actually area is eating disorders, right? So watching really carefully, like if you have a patient or an individual that has just kind of recovered or is in the recovery phase of an eating disorder, then again, this is a life and death illness. This isn't just like having a bad day type of thing, right? Anorexia is the highest mortality of any of the psychiatric illnesses. So this is very serious. And I definitely think that's, especially with these long fasts, that's something to kind of take into consideration, that maybe they should not be, maybe not fast this Ramadan. Again, you're talking about, life and death situations, and it's something to be taken seriously. And there are exemptions for this reason. So those are just kind of a few. And there are some interesting case reports and some studies. More and more people are writing about it. So it's really interesting to look into.
Really good points. Thank you. And then I want to go into the hospitalization issue. I know there are a lot of families that don't understand the process of being hospitalized for a mental disorder or being admitted into a psychiatric ward. What steps must be taken prior to hospitalizations? And then what conditions do you think warrant hospitalization? And then how can families be supported, or what are some steps that they can expect to know from the process as well?
Okay, that's a very good question. And again, I think it's important to talk about so that exactly people are kind of prepared or kind of have an idea. Basically, we talk about hospitalization, honestly, when there's any kind of doubt or any kind of thought that we're worried about the safety of the individual, especially if there are thoughts of self-harm, suicidal thoughts, especially if there's a specific, and we ask these questions outright, like we're not afraid to ask them. We have to ask them in our assessment, which is kind of, that's kind of a myth too, that talking about suicide is going to make it more likely that somebody will. Actually talking about it, that's how you're going to find out what's going on. And so if somebody is struggling with thoughts of hurting themselves, suicidal thoughts, especially with a plan or intent, then that's kind of when we really kind of look into this as an option. If I feel that a person cannot be monitored, they require monitoring 24/7, then that's kind of a sign, okay, that's kind of impossible to do. Even if you're in the house with somebody, sometimes it can be impossible to do. Then this could be possibly, okay, we need to talk about hospitalization. And really kind of the best case scenarios are when I can work with families and talk to them, and we look at it very logically. I know that it can be obviously a scary alternative or a scary choice, or of course scary scenario for most people, but I really reassure them that I talk to them about the hospitals that I'm familiar with. I don't work at a hospital, but oftentimes I know the psychiatrists that work at specific hospitals, and I'll be like, oh, I can text them right now and just see if they have a bed, or and that sometimes that can help people feel a little bit more comfortable. These days, also, I think, of course, again, there's so much of the unknown, and there's a lot of misconceptions. These days, people are not in the hospital for even weeks at a time anymore. They're not in the hospital for months at a time. It's really, the purpose is to kind of stabilize, where you can maybe they're observed, and They have sometimes groups, group therapy. They meet with a psychiatrist. They meet with a social worker. They have nurses that are kind of on the floor. And of course, oftentimes, they're really there because they're going to go ahead and start medication. And in my experience, they're not crazy doses or anything like that. They're kind of the same doses that I would start, low and go slow in an outpatient setting, but they can observe how that person is responding to that medication. These days off, actually, people are really not in the hospital for very long at all. And sometimes it can be kind of a challenge even to get in. Sometimes I might recommend that someone needs to go in. By the time they go to the crisis center, the emergency room, that person might do their own assessment and might feel like that they're safe to go home. So it's not an easy process. There's many, many kind of checks in the whole system. I guess what else? I think that helps parents and families feel comfortable is when they know that their outpatient psychiatrist is communicating with the doctor. That's not always possible. That's not always a possibility, of course, but that does kind of help put people's minds at ease. It's really not like what they show in the movies anymore. They have recipient rights. They have a recipient rights representative at every hospital, that's kind of going over cases and making sure that everything that, that people's rights are definitely being fulfilled. It's very rare, that there are cases also where a person doesn't want to be hospitalized. There is involuntary hospitalization, but even that, there's a whole process. That's a doctor has to give the specific reasons. And it's usually like either they're suicidal and they're really worried about their safety or safety of others. Another scenario is postpartum. If there is a postpartum depression, and especially if it's teetering into, this is rare, but teetering into postpartum psychosis, where we're worried about the mother's health and the mother's ability to take care of the baby, then that's another kind of like a psychiatric emergency that she would need to be hospitalized. It's another example.
Well, thank you for giving us that feedback, the background, because a lot of people don't know what's going to happen if they actually hospitalize. There are a lot of people that check themselves in, but it's good to know what the process is like. Mm-hmm. The next area I want to talk about is trauma and suicidal patients. How do you work with them, and what treatment options do you use?
Do you mean patients that have trauma that are dealing with suicidal thoughts, or
yes,
as well as,
or just either or?
Trauma is, this is an area that we are talking a lot more about, which I think is wonderful. If any of you are interested, and I'm sure you've read the book too, The Body Keeps the Score is an amazing book about trauma and PTSD. And that's basically all about childhood trauma and how it manifests in adulthood and in kind of how our body carries that trauma. And it's a very fascinating read. It's all about kind of how memories are kind of the traumatic memories are stored differently than our regular memories. And that's why individuals kind of relive them in a different way. And by trauma, I mean, like, he talks about the cases are really, really heavy and they're sad, but basically like years of, for example, sexual abuse or molestation from somebody that the child trusted. And a person could go through their life, it looks totally normal, and then something can happen where all of a sudden they're just having panic attacks, they're having crying spells, they're having like these weird nightmares, things like that. Many of you have probably heard of the ACEs study, Adverse Child Events kind of score. We were looking more into this too. Basically, they have a list of adverse child experiences that people go through, and how, thank you, Dr. Sekandari. The Body Keeps the Score by Bessel van der Kolk. I just heard a talk by him yesterday too. But that book is amazing for any of you who are interested in PTSD and trauma work. And there's others really good books too, but that's an amazing one. So this is, so basically ACEs is kind of a new thing where, we're looking at actually not just how these adverse child experiences affect mental health, but how they affect physical health. I don't know the exact, I don't have the exact statistics offhand, but they're directly related to, it's significantly increased risk of cardiovascular incidents, stroke, heart attack, higher incidence of autoimmune. There's a link between autoimmune diseases because, and that's what the title is. It's that even when we're not acknowledging the impact of these highly traumatic events, they are impacting our bodies in some way. So trauma is really huge. And that's again why we as psychiatrists take a lot of time to get a very good history. I'll say right now, the way that the insurance companies are, and even kind of some systems, they really want us to like crank out these, do med reviews and evaluations in a really quick time. Like they want us to do them in 30 or 45 minutes. They want us to do medical, to try to get people in, and is one reason, but 15 minutes. And it's like, you can miss a lot of those things if you are not spending enough time. I've had people that I've been seeing for a long time, and sometimes you can ask the question, and I'm sure you've had this experience. You can ask questions about childhood trauma, or has anybody, do you have a history of abuse? And the person might deny it, and then, or they didn't really put two and two together, or kind of even recognize that this was a traumatic event or a traumatic period that they went through in their childhood. And then you're seeing them and they have the anxiety. Oftentimes the anxiety that I see is very difficult to treat until we look at the root cause, and they'll be like, actually I have gone through a traumatic experience and I didn't even really link it to what's going on now, or I haven't really allowed myself to go back there. I've had many, more than a few times, mothers that have come in, and when they have their own children, especially when their children, their daughters, the same age that they were when they endured trauma, then that can actually be a trigger for them too. So oftentimes we're seeing people that have been triggered in some way, and it's kind of like reactivating these kind of really fragmented memories. So, what do we do with that? We definitely make sure that they're in therapy, of course. And when with a skilled therapist, it's not that you go in and you expect the person to just talk about what happened. Like I said, these memories are stored in a different way, and they can oftentimes be really fragmented and, of course, very painful. So it really takes a special training and special, you want to make sure that their therapist is really skilled in this. And actually, there are some different types of treatments too. He talks about it in the book as well, but EMDR is one. Oh my gosh, it's basically like eye movement desensitization therapy. And it's really interesting actually if you want to look into it. But basically, you are kind of having the person talk about some of those memories, and you're having them focus their eyes, and they're actually kind of trying to uncouple that memory from like the deep-seated traumatic memory, I guess is kind of the way to say it. You're kind of trying to uncouple the biological component from that memory. It sounds kind of strange, but it can be really successful. And then from my point of view, we're like trying to prescribe, we'll use medications to kind of dampen that fight or flight, because oftentimes individual feels like they are in survival mode and they're in fight or flight mode all the time. So you're basically just trying to kind of help them calm down a little bit and help ease their anxiety. So we'll use medications for anxiety and depression.
Yeah, trauma is something that, especially prolonged trauma, is not something that you should handle by yourself. You should go to somebody that's trained, because there are things, like you said, people don't put two and two together. They might have a traumatic experience from childhood that's resurfacing, that they're getting triggered, and going to a trained mental health professional is really, really important. And I'm an EMDR therapist, and I love doing EMDR. Especially for people that have trauma that they might not have the words for. They can have it, or they don't want to rehash the whole experience, because I don't do the eye movements. I have the zappers in the hand, so that there's like little pulses that go from the different points of from one hand to the other, because it's integrating both sides of the brain.
Yeah.
And it diffuses the whole, like, trauma is stored, to me, the way I understand it, as a fresh picture, and it doesn't go away. Where, memories can be fuzzy, where trauma is just fresh. But what EMDR does and the trauma work does is it makes that picture fuzzier and not as sharp, so that you still have a memory of it, but it doesn't have the energetic hold on you. And so people have been able to work on their trauma and move forward and live a healthy life. So if you're dealing with prolonged trauma, please seek help, find ways to understand it better and work on it and process it. There is hope. There is a way for you to move forward and not have to be burdened by it. Give us your top 5 strategies for better mental health.
Okay. That's a good one. Top 5, I think having a good support system and not being afraid to reach out. Oftentimes when we're feeling really stressed out or really bad, our instinct is to kind of withdraw, but and it can take a lot of energy to, even pick up the phone and text somebody or call somebody that even if you're not talking about what's stressing you out, just being able to laugh with somebody. So really being able to identify who in your support system is somebody that you can call when you're not feeling down. I mean, when you are feeling down. And sometimes there's people that say things and they're trying to be helpful and it's not. So, again, the people that really do kind of help lift you up. So having a good support system, which I know can be hard for some people. It can be really hard, especially right now if you're living alone, but you really have to almost be proactive in seeking that help out. Definitely knowing what your triggers are. Like I mentioned, watching the news or something before you're going to sleep, if you know that's going to make it hard for you to sleep or you're going to have bad dreams, things like that. Identifying those triggers. Also recognizing your feelings, not trying to push them away. But if you feel a certain way, if you're feeling negative or, again, the more we try to push those feelings away, the stronger almost they feel. And really naming it there's a saying, naming it can kind of tame it. Can tame that feeling. And that's also, if you have kids, that's you're leading by example. The way that we manage our own anxiety is kind of, we're teaching our kids they're watching us, whether we realize it or not. And you will notice that your kids are kind of going to deal with their anxiety in similar ways as we are, or not deal with it. And it comes out in other ways. Not being afraid to get that professional help. Oftentimes, yes, it can really help if you have that, if you're lucky and fortunate enough, maybe ask for personal references for therapists. And if you do have a negative experience, I would say not to give up on therapy as a whole. Sometimes it does take time to find the right fit. Somebody gave a nice analogy. It's kind of like if you get a bad haircut, doesn't mean that you're never going to go and get a haircut again. Just maybe you need to find somewhere else to go, or maybe even talk to the person and let them know like why it wasn't working for you, or is there another approach that you can take. And also, again, not kind of being afraid of seeing a psychiatrist if you feel like it's gotten to that point, or even if it hasn't gotten to that point. Like I was saying, you just want to get another opinion, a kind of fresh set of eyes. Again, I don't know if I mentioned this, but we are trained in therapy. We get lectures from, and that's part of our training is having long-term therapy patients, and really honing in on the diagnosis and trying to figure out things and put things together. And we're used to working with other medical doctors, your OBGYN, your primary care physician, as well as your therapist, teachers, and all those people. We are kind of helping to put all the pieces together. There's another analogy that a friend uses, that medication can be if you do feel like you're drowning, medication might be the life vest, but therapy is kind of helping the individual learn to swim. So it might kind of help you in the short term get up, rise up and feel, save you from drowning. But therapy is kind of teaching you those life skills and those coping skills. So not being afraid to get help from both therapist and a psychiatrist if you need it.
I heard another analogy where, well, this isn't regarding to ADD, where the medication is like turning the light on, but you still have to learn how to read. So if you're trying to learn how to read, you can't do it in the dark. Medication will turn the light on. You still have to do the other work as far as managing.
Oh, I like that.
Yeah. So there's different analogies. So we'll open it up to questions, and then we can, let's see. One of them is drug treatment and pregnancy, and then should one continue or stop? So what should people do if they have like anxiety or bipolar or any mental illness, and then they have to take medication while pregnant?
Definitely, again, like with everything, talk to your doctor, and I would say maybe reach out. If you're not seeing a psychiatrist, talk to a psychiatrist about it too, because I have had cases where a primary care physician has actually stopped all medications. It's really important that the mother is taking care of herself too. We definitely know that there's actually negative effects of untreated depression as well, both during pregnancy and postpartum. There's actually a risk of IUGR, intrauterine growth, smaller babies basically. And basically a risk of, if there is untreated depression, it can really affect the mother's ability to bond with the baby. And if you have a history of postpartum depression, especially, there's chances are, with other subsequent pregnancies, that these women are most likely going to have other further episodes. Again, every medication is different. Definitely for depression and anxiety, we do have a lot more pool. We have a larger pool, I guess, of evidence. Obviously, we can't do studies. Ethically, we can't do studies where we're comparing pregnancy or not. But they have registries where they have people on medication, and they kind of put their name on this registry saying, I'm on this medication, and what the outcomes of pregnancy were. A really great resource is womensmentalhealth.com, and that is a Harvard-based website, and it has everything related to pregnancy and medication.
Next one is, what should you do if you struggle or to believe in the efficacy of a drug or drugs in general for mental health conditions? Do you think it would help if doctors educated patients as to the effects?
Yeah, definitely. I mean, that's part of the doctor's job, is to kind of, provide that education. I don't know. I mean, I guess it kind of depends. Read about it, I guess. I think there is, again, some misconceptions, or I know that some people feel like, actually, a lot of our medications do have kind of a high placebo effect. And so that's why there's many people that are like, oh, well, it's placebo. And there's certain situations, even when I see somebody and they feel better, they tell me they start feeling better, within days of taking a medication, I'm kind of like, well, I'm glad they are, but that might not exactly be the medication. It does take a few weeks to start working, but the point is that they're feeling better. And usually that placebo effect is not going to continue to last weeks and weeks. It might be kind of, you know what I mean, initially. I guess, and there are a subset of people that medications are not going to work, or, they might try all different types of medications, which can
try other strategies.
Yes.
Ways to go.
Exactly. Like we said, there's no magic pill. So you has to be in conjunction with all those things.
But I want to say something about the placebo effect. People look down on that oh, it's just a placebo effect. But do you know how powerful your brain has to be to take a sugar pill and actually make it work for you? I mean, that just talks to the power of the mind. And I love the placebo effect.
Good.
Take advantage of it. Yeah.
Oh, no, just thank you again for just inviting me. Thank you so much. I feel so honored. I've been watching your work and just love everything that you're doing. And so I was really honored to be a part of it. So thank you so much. And thank you everybody for tuning in too.
Thank you so much for being here. And I really appreciated all the information you shared. So thank you. If people wanted to find you, where can they find you?
I have I'm not on Twitter, but I have an Instagram account.
You're active on Instagram?
Yeah.
Okay. Okay. Well, thanks again.
Thank you so much for doing this. Thank you. And you too.
Take care. Bye-bye.